I start with a 25 gauge needle to anesthetize the skin, and then a 21 gauge needle or 22 gauge needle to anesthetize the tissue just beyond the skin, and then I'll transition to a spinal needle 18 gauge, and I'll use that to inject initially posterior to the lesion, and then anterior to the lesion, and then along the path that the cryoprobe would take. It also kind of gives me an idea of which approach I should take to approach the lesion, because sometimes, you know, the breast moves, and it allows you to at least kind of do a trial run by insertion of the local anesthetic needle. You know, that would at least give me an idea of how I would approach the tumor with the cryoprobe. I also inject beyond the lesion, because for a small lesion, as you know, the cryoprobe has to project not just into, but past the lesion. So if you haven't anesthetized the tissue past the lesion, patients will often complain of pain in that location when the cryoprobe is introduced. So the idea is to inject liberally, local anesthetic. Usually that's the most uncomfortable part of the procedure. The rest is relatively pain-free. So if you are attentive to injecting local anesthetic up front, it's a relatively easy procedure for patients to tolerate from that point on.